Surviving a heart attack or stroke represents both a victory and a warning. The victory is obvious. You survived a life-threatening event. The warning is that your cardiovascular system has revealed its vulnerability, and that vulnerability persists and in some ways intensifies. Research shows that individuals who've experienced one cardiovascular event face dramatically elevated risk during winter months compared to summer, with recurrence rates 3 to 4 times higher in cold weather. Understanding why survivors are particularly vulnerable and how to protect this at-risk population deserves focused attention. The physiological reasoning makes sense when you think about what a heart attack or stroke leaves behind. Even with excellent medical intervention, there's typically residual damage. Scar tissue in heart muscle doesn't contract normally. Blood vessels that have experienced acute events may have persistent endothelial dysfunction. The atherosclerosis that caused the first event hasn't disappeared. It's been managed but not eliminated. Other arteries likely contain plaques similar to the one that ruptured. This is a cardiovascular system already compromised, already weakened, and cold weather stresses it precisely in its areas of weakness. Medication metabolism can change seasonally, something rarely discussed with patients. Some cardiovascular drugs are affected by temperature-related changes in blood flow, kidney function, and liver metabolism. A medication dose that's perfectly calibrated in summer might be insufficient in winter, or conversely, might accumulate to excessive levels depending on the specific drug and individual factors. This variability can leave survivors inadequately protected during the highest risk season. Psychological factors compound the physical vulnerability. Many survivors experience anxiety about winter, knowing it's high-risk season. This anxiety itself triggers stress hormone release and sympathetic nervous system activation, ironically increasing the very cardiovascular stress they're worried about. Depression rates increase in winter generally, and depression is a significant independent risk factor for recurrent cardiac events. The combination of valid fear and seasonal mood changes creates a psychological component to winter cardiovascular risk that deserves attention. Physical activity patterns change dramatically for survivors in winter. Someone who walked regularly in summer may stop in winter due to cold, ice, and darkness. This deconditioning reduces cardiovascular reserve precisely when it's needed most. The social isolation that winter can bring, particularly for elderly survivors, reduces the likelihood that someone will be present to recognize symptoms and summon help if another event occurs. What should survivors do differently in winter? Enhanced monitoring is essential. More frequent blood pressure checks, weight monitoring for fluid retention, closer attention to symptoms. Some cardiologists recommend seeing survivors monthly during winter months rather than the typical quarterly visits. Medication adjustments may be necessary, either dose changes or adding additional protective medications temporarily during high-risk season. The exercise program needs winter-specific planning, whether that's indoor walking routes, gym memberships, or home equipment that maintains activity levels when outdoor exercise isn't feasible. Symptom recognition education needs reinforcement. Survivors and their families should review warning signs before winter arrives, know exactly what symptoms require immediate emergency response, and have action plans prepared. Cardiac rehabilitation programs should include winter-specific education modules. The key message for survivors is that winter isn't just another season. It's a high-risk period requiring heightened awareness, proactive measures, and close medical partnership. The goal is transforming statistical risk into managed risk through knowledge and action.